Actinomycosis. Gram stain of aspirate from an oral abscess. Actinomyces frequently grow in aggregates termed as sulfur granules, and note that the branching gram-positive filaments on the edge of these granules. So definition-wise, it is caused by anaerobic gram-positive bacilli. Infection is slowly progressive, may disseminate or invade the tissue locally, leading to sinus tract formation. It is usually a very rare condition, more common in men, but there are some predisposing factors behind it, like a corticosteroid use, chemotherapy, organ transplant, or HIV infection. Clinical features are divided into thoracic and extrathoracic and other sites. Thoracic symptoms include non-specific cough, chest pain, hemoptysis, fever, anorexia, and weight loss. Chest wall involvement may be in the form of sinus formations, rib infection, and empyema. Extrathoracic disease like soft tissue infection of the head and neck, especially mandible, discharges sinuses. Other sites are abdomen, ileocecal region, pelvis, fever, liver, bone, CNS abscesses. Chest X-ray and CT appearance. It is variable, not very diagnostic, may include masses with cavitation, pulmonary infiltrates, or consolidation. There might be a mediastinal disease and pleural involvement. Diagnosis is by microscopy and anaerobic culture of the infected material. Specific stains and culture conditions required. Most important is the yellow sulfur granule. They are diagnostic. Contain aggregate organism, may be observed in infected material. Samples: sputum, pleural fluid, or pus from a sinus tract should be taken and sent for cultures. Inoculate into anaerobic transport media, rapidly transport to lab. But keep in mind the endobronchial biopsies have a low sensitivity. Infection characteristics: most infections are polymicrobial accompanied by anaerobic or aerobic bacteria. Consider in patient with a pulmonary disease and concurrent soft tissue infection of the head and neck. Actinomycosis diagnosis is often suspected. Clinical and radiological features may be misleading. So pulmonary and soft tissue infection, especially involving the head and neck, should think of actinomycosis. It is similar with nocardia, so we have to differentiate it with nocardia. Nocardias are delicate filamentous gram-positive branching rods. How to differentiate it with actinomycosis? Nocardia grow on acid-fast staining under aerobic conditions. Actinomycosis is anaerobic. This is some differences between nocardia and actinomycosis. Treatment regime for actinomycosis. So the regime starts with high dose penicillin for antimicrobial treatment of actinomycosis. Initial parenteral therapy for severe infections like penicillin G, 10 to 20 million units daily in divided doses, or ceftriaxone is an alternative. Mild infections and oral step-down therapy can IV to step down to oral penicillin or amoxicillin is an alternative. If patient is allergic to penicillin or cephalosporins, doxycycline can be used as an alternative. Others macrolide and carbapenems. Duration of treatment: initial parenteral therapy in severe infections continue to 4 to 6 weeks before converting into oral therapy. Prolonged total duration of antibiotic therapy may be 2 to 6 months for mild disease, 6 to 12 months for severe disease. Polymicrobial infections adjust therapy according to the culture, isolated organism, and sensitivities. In some cases, surgical debridement may be needed if it is complicated, like critical space massive hemoptysis, extensive abscesses, or fistulous tract. Monitoring, careful monitoring response to treatment, incorporate imaging into follow-up to ensure appropriate resolution. So, BCQ's time. Which of the following is the preferred initial parental therapy for severe actinomycosis? Is a 45 years old male with a history of organ transplant and HIV infection, present with symptoms of chest pain, cough, weight loss. Imaging studies reveal pulmonary involvement in chest wall sinus formation. Microbiology lab suspect actinomycosis. Which one of the following is preferred in severe? Is it amoxicillin, ceftriaxone, Clinda, or penicillin G? Next question. 30 years old female patient presents with a discharging sinus and mandible and a history of a dental procedures. The clinical examination and radiological features are suggestive of actinomycosis. Patient is allergic to penicillin. Patient is allergic to penicillin. Which of the following is the recommended non-beta-lactam alternative for antimicrobial treatment in this patient? Is it carbapenem, doxycycline, macrolide, or clindamycin? Next, 50 years old female present with a history of actinomycosis, present for follow-up after completing antibiotic therapy. The clinician plans to repeat a radiological studies to assess a disease resolution. According to the recommendations, at what time interval should the follow-up imaging should be obtained? So this question is judging how to monitor a patient in actinomycosis. Is it 1, 3, 6, and 12 months after completion? 6 or 12 months after completion? 1 and 6 months after treatment completion, or only if symptoms reoccur after treatment completion? Last, 65 years old male present with actinomycosis and extensive abscesses and fistulous tract is being considered for surgical management. Which of the following statement regarding surgical management in actinomycosis is correct? It is generally not recommended for mild infections. It is warranted in all cases of actinomycosis. Is it surgical management is only required in cases of abdominal involvement, or surgical management may be warranted into complicated cases with extensive abscesses and fistulous tract?